our European colleagues are actually ahead of us in this, and I'm going to let Anna speak more about this, but they are routinely doing NGS, and the NCCN guidelines actually suggests that if feasible, this should be done in all endometrial cancer patients. However, when there are limitations, surrogates can also be used, and in this schema, you can see that you can do just POLE sequencing, and if there is no POLE hotspot, then you can check for mismatch repair IHC, and if if the expression is lost, they're MSI high, and otherwise you do P53 immunohistochemistry, and then if they are normal or wild type, they would be in the copy number low bucket, and if it was aberrant, they would be in the copy number high. So, two ways of really looking at this. This is kind of a surrogate classification that can also be utilized to do the molecular subgrouping. I think it's really important to remember that endometrial cancer has the highest incidence of mismatch repair deficiency, 25 to 30%, and that surpasses that of colon and stomach adenocarcinoma, which you see here. This is just differentiating the two tests. Mismatch repair protein is the IHC test, and it looks at the four proteins that I talked about: MLH1, PMS2, MSH6, and MSH2. And then the MSI testing, is essentially the phenotypic evidence of loss of dMMR, and this can be done by the standard 5 microsatellite markers, or it can be done through NGS. I think these terms are important. dMMR MSI refers to mismatch repair deficiency. PMMR MSS refers to patients with mismatch repair proficiency. So universal, I think it's important to recognize that at minimum, we think that mismatch repair IHC is important. And this is because it provides an opportunity to determine which patient should then get referred for genetic testing to rule out Lynch syndrome. It also informs treatment decisions in the recurrent setting, and it's going to generate really valuable information, especially as we hear about immunotherapies potentially moving into the frontline setting. So obviously, with this changing landscape, it is really important that you have, some very open discussions with your pathologists and collaborate with them. And we recently had to do this at our institution, and we have now, come to the idea that we are going to be doing NGS testing on all our endometrial cancer patients at the time of diagnosis. So in order to do this, you really have to work with your pathologist, make sure that they know that they will be doing this, make sure that there's adequate specimen, and really communicate and work together in making these changes. Just really a little bit of background about immune checkpoint inhibitors. So they work by blocking the T cell inhibitory signal, and essentially they activate T cells. And this landscape is rapidly expanding, and you're going to hear more of this data in a little bit. The predictive biomarkers, especially in the recurrent setting, are really important as we think about utilizing these therapies. These are again, the January 2023 NCCN standard of care. The preferred regimen, systemic therapy for primary adjuvant, is carboplatin paclitaxel. Or carboplatin paclitaxel with trastuzumab in stage 3 or 4 HER2 uterine serous cancers. So we also test for HER2 for this reason. And then in the recurrent setting, we go to biomarker-directed therapy with either lenvatinib pembrolizumab if they are microsatellite stable, or pembrolizumab or Dostarlimab are the two that are FDA approved for the deficient mismatch repair tumors. And so, again, this is, at minimum, MSI dMMR testing is important because it really helps us in terms of the therapeutic choices we make in the recurrent setting. So this is just to kind of reiterate what I just told you. Okay.
So in my excitement to tell everybody what great friends you were, I didn't even say your title or anything. So Bob, I apologize. So Dr. Pathuri is full professor at the NYU, where she leads the clinical trials office, and within GOG Partners, she also leads our DEI initiative. So Bhavna, thank you, and I'm sorry for not recognizing your wonderful accomplishments, but my iPad's blowing up. Not but. Now my iPad's blowing up, okay? So tell me what you're doing again at NYU. You went through that quickly.
Okay.
But then, okay, we have a lot of patients, a lot of people here in the audience that serve low and low-resourced patients and groups. Even at large institutions, there's patients with low resource. We worry about the financial toxicity. We worry about this. So tell me about what you're doing at NYU, but tell the audience what else, and then I want to hear about the European experience.
Yeah, so what we have decided to do is NGS testing on all our endometrial cancers up front. So, and in addition, we also do HER2 testing, IHC, and I think and a surrogate for doing NGS is actually using immunohistochemistry. So you can do P53, and those would be, if they're P53 positive, they would be in the copy number high subgroup. And if it's a normal or wild type, then they would go into the copy number low, which are your more endometrioid type. And at minimum, I said everyone should have mismatch repair IHC. So that's kind of the if you are in a resource limited setting, mismatch repair IHC, P53 IHC, I think is the minimum that should be done today.
All right, I want to come back to that. And tell me what you guys are doing in Europe, because you are so far ahead of us with regards to early stage disease.
We try to be.
I hate to admit that. I just admitted it on stage, but yes.
So, thank you for the question. So, in Europe, we have realized the importance of molecular classification to treat our patient with endometrial cancer. So, we have recently published our ESMO guideline in endometrial cancer, and we strongly recommend that all patients diagnosed with endometrial cancer must have a molecular classification, at least, as Vanna mentioned, based on mismatch repair status, P53, ER, and PR status. Ideally, all patients should also have polymutation status, because we know that the polymutation status change the classification of this patient. But I think this is another level. But at least mismatch repair status, P53, and hormonal receptor status should be mandatory for all patients with endometrial cancer.
All right, so we have what our minimum is.
A minimum.
Now getting NGS, poly, you do spot mutations for the poly, which is great, and that would be potentially an option. But there's no way that I'm going to be able to order NGS on all of my patients in early stage endometrial cancer. Bob, now, what should we be doing in that scenario? Should we be taking just those with grade 3 tumors that it may change us or push us in one direction on treatment about systemic therapy versus local therapy? Should we be using some other potential triage system? I know there's not data to say that, but we have to be practical here.
Right, no, absolutely. So I think in those resource, limited settings, thinking about whether it's going to impact adjuvant therapy. And if this, the higher grade tumors, the, deeper invasive tumors where you may be giving therapy may be the ones that you would do the hotspot poly testing on. Because, the ESGO ESTRO guidelines actually allow you to de-escalate therapy in those patients.
Absolutely. I mean, if I may,
Please.
in our ESMO guideline, we recommended try to have polymutation, hotspot mutation, at least in stage 1 or 2, because we know that those patients in stage 1 or 2, if the tumor harbor a polymutation, we can de-escalate therapy, and then they can avoid receiving any adjuvant therapy. In the stage 3 and 4, there's a lot of controversial because there are no reliable data about skipping adjuvant therapy, but in stage 1 or 2, grade 3, it's highly recommended have hotspot mutation.
And with advanced stage, we don't have enough data yet to de-escalate.
Exactly.
But in the early stage where you have a decision, chemotherapy, vaginal cup brachy, whole pelvic radiation, all the above, the polymutation may significantly impact your recommendations, all within NCCN guidelines.
Absolutely.
Right. And I just want to make one other point is, the FIGO staging is going to soon change, and it's based on molecular staging. So it's going to be even more important that we start incorporating these now.
Well, this is a great discussion, and we really could do all day on local regionals, but I need to move on. Our next speaker is Professor Ana Oken, joining us all the way from Barcelona, Spain. She leads the ENGOT for Spain, and we met, it was at SGO in Miami, I believe, and have been friends and collaborators ever since. So, Anna, let's hear about the advanced metastatic disease.
Thank you, Dave, for the kind introduction. Thank you all for being here with us today. So, Vanna has already very nicely explained the rationale for using immunotherapy in endometrial cancer. So the question is, where do we stand right now with checkpoint inhibitor in advanced or recurring endometrial cancer? You are aware that there are several agents that are under clinical development. However, in interest of time, now we are going to review only those agents that have already been approved by regulatory agencies, namely Pembrolizumab and Dostarlimab, and they have incorporated in the phase 3 trial that we will see the result this Monday, and Durvalumab. We have data from the phase 2 trial with Durvalumab, and Durvalumab is also incorporated in one of the phase 3 trial in first line that we will see in the upcoming months. So, what we know about Pembrolizumab? You know that following the early signal efficacy activity of Pembrolizumab, the Keynote 158 is a kind of confirmatory trial. In this phase 2 trial, we enroll different kind of solid tumor in different cohort, but for sure today we are focusing the endometrial cancer cohort. In this cohort, we enroll patients with recurrent or advanced endometrial cancer. All patients must have progressed at least one prior line based on platinum therapy. And all patients must have measurable disease. Patients were eligible if their tumor harbor a MSI or dMMR characteristics. So all the patients receive Pembrolizumab, flat dose 200 milligrams every 3 weeks, for 35 cycles, progression of the disease or unacceptable toxicity. Primary endpoint, very important to understand the activity of any single checkpoint inhibitor in endometrial cancer. Primary endpoint, overall response rate per RECI. Secondary endpoint, duration of response, and PFS. So, as you can see in the slide, the data provided by Pembrolizumab monotherapy are really compelling. The overall response rate was 50%, complete response 16%, partial response 34%. But please, always when you look at the efficacy data from any kind of checkpoint inhibitor, look at the duration of response. The duration of response reflects the magnitude of benefit that we can obtain from using checkpoint inhibitor. And here, as you can see, the estimated duration of response and 4 years was 66%, an amazing durable response. Moving forward, we have the GARNET trial. As you are aware, GARNET trial is the trial that led Dostarlimab approval in both Europe and FDA in the US, in those patients who have advanced or recurring endometrial cancer harboring a dMMR mismatch repair deficiency, MSI high tumor. What do you know about the GARNET trial? GARNET trial is a phase 1b trial that, we started, trying to identify the recommended phase 2 dose, and later on we have different expansion cohorts. Today, we are reviewing the expansion cohort for endometrial cancer focused on dMMR MSI high. So we enroll patients who have received at least one previous line of platinum therapy, either for advanced recurrent disease or for metastatic disease, and a maximum of 2 prior lines of therapy. Importantly, we determine the dMMR status locally by immunohistochemistry, and all patients receive Dostarlimab in the recommended phase 2 dose, 500 milligrams every 3 weeks for 4 cycles, followed by 1,000 milligrams every 6 weeks until progression or prohibited toxicity. Once again, primary endpoint, overall response rate and duration of response. As you can see here, the compelling activity of Dostarlimab in this population. And in addition, let me tell you something. The GARNET trial is the trial that has the largest number of patients with dMMR treated with a checkpoint inhibitor. Overall response rate, 45.5%, complete response, 16%, partial response, 29%. And once again, look at the duration of response. The median duration of response has not yet been reached for those patients who have obtained a response to Dostarlimab. Indeed, when we look at the probability of remaining in response at 2 years was 83.7%. So, and then the Durvalumab study, the FIGO study. This is a study that enrolled patients in 2 different cohorts. It's not a randomization of the patient in the 2 cohorts. Those patients who had a dMMR tumor, they were put in one cohort, and those patients with PMMR, they were in the other cohort. All patients received Durvalumab, every 4 weeks. Once again, primary endpoint, objective tumor response by RECIST. So what we learned from the trial is something that we have learned from another previous one. The overall response rate in the PMMR population is quite poor, only 3%. However, in the dMMR, once again, we saw a compelling activity with 47% of responses. So, we have seen that there's no doubt that the checkpoint inhibitor works very well in the dMMR MSI population, but we wanted to improve even more the activity. So we have developed some combination that may have a kind of synergistic effect. The most developed combination are with anti-angiogenic agent, with PAR inhibitor, and with chemotherapy. Chemotherapy, you will see on Monday. I invite all of you to attend the session. So one of the most developed combinations so far is with anti-angiogenic agents. You know that initially we learned the activity of lenvatinib plus pembrolizumab from the phase 2 trial Keynote 146, and the results of this study led to accelerated approval by FDA and Australian regulatory agency. And in light of these results, the phase 3 was launched. And the phase 3, the Keynote 775, I know that you know very well, but I will, review the top data. This is a phase 3 trial that enrolled patients who have received prior platinum therapy. First thing that you keep in mind, all patients have previously received platinum therapy. And then the patients were stratified according to the mismatch repair status, mismatch repair deficiency and mismatch repair proficiency. Among those patients with mismatch repair proficiency tumor, then we have another stratification factor as region, ECOG, previous history of pelvic radiation. Then patients were randomized in a 1-to-1 fashion to experimental arm, namely lenvatinib plus pembrolizumab, or a standard arm, that is physician-choice chemotherapy, either doxorubicin or weekly paclitaxel. Very important primary endpoint. In this case, we have a co-primary endpoint, PFS and overall survival. And you know, but I will remind you, this trial had a hierarchical analysis, fairly PMMR, and then all comers. And then you can see here the trial met its primary endpoint. The combination of pembrolizumab lenvatinib was superior to chemotherapy in the PMMR population and in all-comer population, In terms of PFS, with a hazard ratio 0.62 for the PMMR population and a hazard ratio 0.56 in the all-comer population. This is the updated data that presented by Vicky Macker in ESMO last year with the follow-up of more than 16 months. And then the overall survival. The overall survival was also superior in the combination of Pembrolizumab plus lenvatinib in the PMMR population and in the all-comer population. When you look at the hazard ratio for the PMMR, 0.70, and when you look at the all-comer population hazard ratio, 0.65. In addition, look at the Kaplan-Meier curve. The patient started to get benefit from the combination, from the pembrolizumab, very early in the patient journey therapy. This is something very important. So here, we have summarized the overall response rate. As you can see, for the lenva-pembro, the overall response rate was 30.4, and for the all-comer, 33.8. And when you look at the overall response rate for the chemotherapy, as expected, 50%. In addition, you have complete response and partial response, 5.8, 26.6 in the lenva-pembro, and in the all-comer, 26.3, 45.0. So then I guess that you're asking yourself, okay, what about the MMR population for this combination? This is something that you need to keep in mind in order to interpret the results properly. This is an exploratory analysis. So in this exploratory analysis for the dMMR population, pembrolizumab was superior to chemotherapy in terms of PFS and OS. And when we look at the overall response rate and acknowledging the limitation of the cross-trial comparison, the overall response rate was 40%. That is quite aligned with the activity that we have already seen with Dostarlimab and Pembrolizumab monotherapy. So that's all that I wanted to say. Thank you.
It's a beautiful summary, and really, just kind of level sets us here about. But I'm just kind of going through this in my mind. But I'm not going to torture you all by making you watch me get anxious filling out polling questions, because that music plays, and I think we're waiting too long. But there were polling questions sent to your iPads. Please complete those, and we won't torture you with making the little timer come up here. Now, speaking of polling questions, we got some good questions coming in, but not polling.
Okay,
all right?
I will be ready.
Okay. We got response rate in recurrent single agent MMR deficient, 45 to 50%, unbelievably consistent. You didn't have time to get in the data too much, but the chance that you, I can't say cured. I'm not ready. I didn't think in my lifetime I would see people with recurrent cancer cured in treatment, but you look at the duration response, 2/3, 4 years, 3 years. I mean, we have a little bit more mature data on 158 than we do GARNET, but if you get a response, there's a really good chance that response is going to last unbelievable, and even stable disease.
Absolutely.
And then we look at the Len-Pem data, 775, we got about 32%. Again, recurrent, but now proficient patients. Just kind of level set, very consistent across. So let's go into the patient case, because I think this will go with the questions that we're getting here. Please fill out the polling questions. So, patient case, just in case you didn't know this was a patient case. 65-year-old, originally presented, she's active, she's retired, she was a teacher. She undergoes a minimally invasive typical surgery. We do sentinel lymph nodes, and she ends up, there's a typo here, she ends up having a grade 2. I like grade 2 rather than grade 1. And she has metastatic nodes, pelvic nodes. She's found to be proficient. She gets 6 cycles of carboplatin paclitaxel, doesn't get radiation. We could debate that, but let's talk more about her therapy. So 4 months after completing her therapy, she presents with unfortunately bad disease because she was having symptoms. They confirm it that she has pretty significant liver disease. Now, so she's proficient. She's gotten previous carboplatin paclitaxel. If I said Taxol, I apologize, paclitaxel. So what are you going to do here?
Honestly, I don't have any doubt that I will offer this patient to receive therapy with pembrolizumab plus lenvatinib. I think, the combination really beat the chemotherapy with either doxorubicin or with paclitaxel, and I think it will be an ideal option for these patients.
So in my mind, she's 4 months. Okay, if she's 12 months, would you go back to chemo on this
No,
patient?
absolutely not. Absolutely not. I mean, it's something that we discuss a lot. I mean, because sometimes, we try to establish comparison between ovarian cancer and endometrial cancer regarding the platinum-free interval. And honestly, I would like to say it doesn't apply in endometrial cancer. This patient have relapsed 4 months later after platinum therapy. I have no doubt that I will not treat this patient with platinum therapy once again. And for sure, weekly paclitaxel, doxorubicin, 15% of overall response rate, short duration of response. Let's go to try pembrolizumab.
And this patient is left with no disease and still recur within 4 months. So clearly chemotherapy, even 12 months. I mean, if she presents 3 years later, we could probably debate it, right?
Absolutely.
Bob, now I'm getting a lot of questions here. These are my friends, so I'm going to call them by their first name. I apologize. But Bob, now we're getting a ton of questions here. Len-Pem's too toxic. Well, what do you think? I mean, 35% response rate, living for years, but I don't want to deal with the toxicity because it cuts into my quality of life.
Well, I think, this is a very effective regimen, and we need to learn how to give this and manage the toxicities, which, can be managed with dose holds, dose reductions, and successful mitigation strategies.
Absolutely agree.
And I was a little tongue-in-cheek because I said mine purposely, not me as the patient, me as the practitioner. We have to learn how to give this. We're going to come back to that, but let's get into some of the fun questions now. Instead of carboplatin paclitaxel, I'm going to start with Anna. She gets carboplatin paclitaxel plus IO.
This is a tricky question.
And because of that, she would have continued, and she's progressing on IO.
Wow.
Now it gets fun. All right, now it gets fun. Because we're going to see some data.
Let me
We're
tell
going to
you
be facing
something.
these
I mean,
questions, right?
We don't have the crystal ball, but we have preliminary data from 2 important studies. One of them is the trial led by the group Bamit Ousa that was published 1 year ago with cabozantinib. And in this trial, they treated the patient with cabozantinib and nivolumab. And then they treated patient just with nivolumab. And when the patient progressed under nivolumab, they added cabozantinib, and these patients were able to respond once again to IO. Preliminary data, a small sample size, but proof of concept. And then we have the LEO trial. The LEO trial that we developed with the collaboration of GOG and ENGOT, lucitanib and nivolumab. And then in this trial, once again, a small sample size, but we treated patients with the combination who have progressed under IO monotherapy, and then we show once again responses. It's something that we need to investigate in a formal, well-designed clinical trial, but there's preliminary data that suggests that, adding an anti-angiogenic therapy for patients who have progressed under IO, they may respond once again.
So preliminary data, clearly we need more data. We're going to talk about some of the trials that are ongoing here at the end. Bob, and I saw you had something to say.
No, I was going to agree 100% with Anna, and I've actually treated patients on both those trials and seen responses in prior IO-treated patients with the addition of a TKI.
Yeah, I've done the same, I have to admit. Again, with very limited data. But these are the real questions we're going to have to face in potentially a very short time. We think. I'm curious to see.
But what I would really recommend in this subgroup is a clinical trial.
Absolutely, I told you. We need formal clinical trial, to address this important question because the landscape of endometrial cancer will be changed in 48 hours. Today is Saturday, so Monday.
Sometime. The next few days. Cut 2 sleeps, as my kids would say. All right. Bob, now your passion for making sure the patient is a shared decision. Well, any advice? We have this slide up with regards to these conversations, which are really data-free zones or maybe data-free zones moving forward. There is, if you recur and you haven't had prior IO, endometrial cancer, some IO. For deficient, it's going to be single agent. Proficient, it's going to be a combination, right? We have to learn how to take care of the toxicities. But I mean, how do you approach the patient with this, as we go through this moving forward?
Yeah, no, I think this idea of shared decision-making is really important because it engages the patient in their treatment. And that really, helps patients, one, be motivated to stay on their drug and, follow up, have confidence that their provider is including them in the decision-making. And so, while patients need guidance, I think they also want some ability to have control over, how they're treated. And so I think, this idea of shared decision-making is key. But I think the onus is also on us to really educate these patients before they start immunotherapy and know, what symptoms to look out for and to report them early, because we know that, immune-related AEs, can be fatal if they are not identified early and treated early.
Perfect segue. Education. So this patient starts in Len-Pem, pretty straightforward answer in our mind of this case, right? So you're going to educate her, but now she's pretty early on. She's about a month into therapy, so she just got her second cycle, okay, of, in this case, Pembro. She's done diarrhea. I'm not going to tell you, let's assume it's in that grade 1 to 2 range, okay? We're not admitting in the hospital, we're not getting called. So how do you approach this patient? Combination therapy, both drugs have risk of diarrhea. Bob, why don't we start with you, and I want to talk to you about then go into some of the timing of some of these IOs.
Yeah, so, these overlapping toxicities are difficult, right? So diarrhea is one of them, thyroid disorders, but it is important to kind of at least try to sort that out. Usually if, when these occur earlier on, especially with diarrhea, I think in my mind, is it mucousy and bloody? And that would be more of like a immune-related colitis picture as opposed to watery. And then holding the drug, if you can hold the TKI and the diarrhea improves, that's another indication. The short life of the TKIs are short, right? So that should subside sooner. And then, thinking about, restarting them at a lower dose, using your antidiarrheals, brat diet in that scenario. But if that's not what you think it is, then you really need to think that it's more related to the IO and treat them very differently.
And the lenvatinib will start a little earlier, right? The colitis will start a little bit earlier. So if they're in between cycles, holding lenvatinib, see if it gets better. If it doesn't get better, then taking your next steps. I think if they present and they haven't called in, we talked about educating them, but we can educate a lot. Some patients are just not going to call in, and they're sitting there. You have to make a decision. I was doing this with Dr. Walker from Georgetown. He's a GI medical oncologist, and we were having a conversation. I go, well, I'd probably hold lenvatinib, but give the Pembrolizumab. He's like, why? The drug, it sticks around for a while. Just hold both and get figured out if you're worried about where you are, because the Pembro will stick around longer. So hold both drugs, figure out, but maybe wait to start your intervention, steroids or other, until you see what they do in the lenvatinib. So speaking of timing, Anna, we've treated a lot of patients on IO, right? When do you start to worry about IO-associated toxicities? Forever? Do you stop? What's your kind of timing?
This is very important. So, patient must be educated on IO toxicity. IO toxicity may appear at any time, not only during the patient is receiving therapy, but even after the patient has stopped receiving therapy. We have seen late toxicity after 2 years under IO. So, firstly, education. And another thing that you need to keep in mind, neglecting identify IO adverse events has a really, really worse impact on the patient's outcome. So, doctor must be educated and patient must be educated on IO toxicity. So there's some kind of toxicity that usually appear very early in the patient's journey as skin toxicity, the most frequent one, followed by colitis and diarrhea and liver toxicity. I mean, colitis and diarrhea usually appear between the week 4 and week 6, but later on we have another frequent toxicity, but we should also keep in mind that is pneumonitis and nephritis. I mean, this is a late toxicity. Pneumonitis is more frequent in patients with lung cancer, but we also have cases in patients with endometrial cancer. So every single time that the patient complain or appear in your office with any kind of symptoms, firstly, rule out that the patient don't have a progression disease. I think the patient have a stable disease, or for sure is in response, in partial complete response, then try to rule out a side effect from IO.
So single agent IO, single agent, very rare to have in the first cycle. I've seen it.
Very rare.
Very rare. So if you're having a combination, but if it's combination CTLA-4 plus, you see it much more frequently, still rare, but much more frequently than single agent. So combination, you will see in the cycle 1 more commonly, but it's really a cycle 2 phenomenon. I educate fairly regularly to my patient, because what's happened is they're cruising along for a year, and they stop worrying about it. And I just had a really bad liver tox at the end of her 2 years of therapy, literally the last cycle. And so continuing education is important. And there are a ton of resources now. When I first started giving IO therapy, I had the ASCO guidelines opened all the time on my laptop. I literally had that as my reference constantly in clinic. The NCCN's updates most recently are actually very good. Started out a little bit rough, but actually are very, very good. And then, Bhavna, you are the senior author on the SGO guidelines.
Right.
So we have multiple references. Having them available, educating our staff, so important. And you know what? I can't believe I'm treating thyroid disease, but you know what? It's not that hard. And counting on the PCP to do it, I mean, come on. It's like, don't count on the primary care to treat their hypertension related to lenvatinib. They will stroke out, okay? Do not do that. Have your plan and get comfortable with it. And I'm speaking to the GY oncologist in the room. Our medical oncology colleagues are just rolling their eyes right now. So we talked about hold the TKI. We talked about the overlap and how challenging it is. It all sounds like we all do the same thing.
Absolutely.
I most recently just, again, just said, gosh, just hold both and figure it out, right? Like, I'm so worried about, I'm holding it. It's sticking around. It's still going to help the patient. All right, so what are we doing from, Bhavna, you really talked about this, right? Now,
Yeah.
where are we on, how do you educate your care extenders? How do you educate the nurses, the advanced practitioners? I mean, they're getting all the phone calls.
Absolutely. I mean, they are the first contact from our patients. So I think it's very, very important, at least once per month, you have a meeting with all your clinical nurses, with all the residents, and you're the fellow, and then review once again all the potential side effects from the combination of IO plus lenvatinib of IO monotherapy, and then review the update in the clinical guideline. Now we have an update from the ESMO IO side effect, and then, they need to keep in mind that one patient receiving IO, they may suffer from any kind of adverse event. Although you think that is infrequent, they may suffer from cardiac adverse event, neurological adverse event, every kind of sign. So you need to be alert every single time that the patient calls you or come to emergency room. And I repeat once again, neglecting to identify these adverse events will jeopardize your patient's outcome.
Beautifully said. Beautifully said. More polling questions are being sent. Again, please look at those. Remember that these CME events are funded by grants, and having that data to show the education of the audience is important. So please fill those out. And I am still getting a couple of questions that we're going to come to. But what's next, right? What's next? Last 15 minutes, 14 minutes to be exact. Last 14 minutes.
13.
Well, 13. They reset it to 14. We're okay. All right, I'll stop. All right. Ruby, GY18. We're seeing them on Monday. We can't wait. We have press releases. It's going to be good. But there's some other trials that are going to make us think with regards to that. We know that, and there's some differences between these trials. This is only part 1 of Ruby, but looking at really carboplatin paclitaxel plus minus Dostarlimab for 3 years. For 3 years. Remember that Dostarlimab, after the first about 6 cycles, is going to then be every 6 weeks. So when we look at this here, there's some slight differences in the design of these trials. But most importantly, Ruby's design was a hierarchical to look at the deficient patients and then the intent to treat, while GYN18 was actually 2 parallel cohorts, essentially 2 trials in one, looking at the proficient patients and the deficient patients. But now with Pembro rather than Dostarlimab, carboplatin paclitaxel. This treatment, in GYN18 actually switched from Q3 to Q6, but up to 5 years of therapy with regards to this. So some differences between, and we're going to really have to look at and identify once we see those results. We know they're positive based on the press releases. How positive, how much does it change? In my mind, proficient patients are a little like HRD negative test patients. In my mind, like, are we going should we give PARPs in those patients in the first line? I haven't seen the data, but I'm thinking about that similar type of conversation. Maybe I'm completely wrong, and it's going to be overwhelming in the proficient population, and we won't have to make such choices. But we will, because we have 3 ongoing trials looking to replace chemotherapy. To replace chemotherapy with our IO therapy. Okay? They're up here. But they may not have the right control arm.
Absolutely.
So now we're going to have to do cross-trial comparison, which is not valid because we never do it. Okay. We also have the ATTEND trial, which is completed enrollment, also trying to answer this question. But we've talked about IO plus chemotherapy, talked about IO plus antivascular. How about IO plus PARP? So Ruby Part 2 is actually plus PARP. DuoE is also with Durva, but plus PARP. You can see in a 3-arm trial. This is also completed enrollment, right? So now, we didn't talk about, I'm going to save it for you, Bhavna, trastuzumab. You're checking HER2/neu, you told us that was not controlled for here or in these trials. So, tell me, what do you think here with regards to where we are in the treatment? What happens if our trials are positive for all comers to the point where we're getting IO therapy to everybody? But now we have a positive, one of 3 trials that are positive for IO therapy to replace chemo. There are no answers to these questions, but we're going to have some fun in the last 10 minutes because I have, as I said, 2 smartest people I know to tell me what to do. Anna, start us off.
So, we don't have the full data yet. We have the press release.
Oh, no, come on.
No, I can't.
All right, they're positive. I told you. They're positive, and they're positive enough. You give everybody.
No, I want to say that,
Yeah.
there's no doubt that we will incorporate IO in our first-line patient with advanced or recurrent endometrial cancer. Without exception, excluding those patients who have any kind of contraindication due to underlying comorbidity, our patient will receive IO plus paclitaxel carboplatin. The point is that we need to start to make the difference between those patients who relapse under IO therapy and those patients who relapse or progress after they have finished the IO therapy per protocol. It will not be the same kind of patient. And then we need to start working on those patients and identify the mechanism of resistance, because it will not be the same. Probably those patients who have progressed after finishing the protocol, I mean, 3 years of Dostarlimab, they progress 1 year later, 6 months year later. Why we cannot rechallenge this patient with IO? I mean, we will need to study, but what happened with those patients who progress after 3 months under IO therapy, or even worse, those patients who progress receiving chemo plus IO? I mean, we have different population, and we need to start to work on these patients to identify all this granularity.
So that's a great point. Somewhat we dealt with in PARP and ovarian cancer, right? The PARP exposed before versus the PARP resistant, progressing on therapy versus a patient who had prior therapy. Bob, I want to hear your thoughts on that. Then I want to hear your thoughts about what are you going to do with a HER2 positive MMR proficient patient who is HER2 positive, she's proficient. Once we see the data, I mean, are we going to be able to are you going to use trastuzumab in that patient or the chemotherapy? But first, I want to hear your thoughts with what Anna just said.
That's a lot.
That is a lot. Jeez, oh, Pisa, that's a terrible moderating job. I'm sorry about that. Just answer everything.
I'm going to answer what I want. No, I'm just kidding.
Yeah,
So,
then just say what you want.
yeah. So, you know, I think one point that I do want to make is that I think this chemotherapy versus IO is still an important question, even though that the standard arm in that will, as you said, you know, be not as relevant, right, with the new data coming out on Monday. And the reason I say that is, you know, we have data in colorectal cancer where, you know, IO is effective. We've seen the recent data presented at ASCO and published in the New England Journal with Dostarlimab, where they had, you know, 100% response rate in the neoadjuvant setting, right? So I think we can't just, I know it's small, but I just don't think we can throw away this idea that IO alone may not be beneficial in the dMMR or the biomarker positive population. And then getting to your HER2 question.
Let's stop there for a second. I'm sorry for throwing so many questions. That was a terrible job of moderating. So we still have the answer, particularly, you know, it was 100% was 11 patients, right? But it's a New England Journal of Medicine 11. It's pretty impressive because it was CRs, pathologic CRs.
CR, 100%.
So the thought that we'll be able to replace chemotherapy, which I think all of us want to do for our patients, right, is still such an important question. We're going to have trouble enrolling those trials with this new data, but go, please.
Yeah, and you know, and you and I have talked about this. The other point I think is really important is, you know, are the, you know, dMMR patients that are not, you know, epigenetically silenced, like with MLH1 methylation, different? And is that the cohort of patients that may even benefit more? We don't know these answers to these questions and need to really look at that.
Particularly from, yeah, I mean, looking at those patients are most apt to respond at the deepest in the, as you said, CR in those 11 patients. So I really am struggling with this, which is the trastuzumab data, yes, it's small, phase 2. Amanda Nichols-Fader, wonderful job. Many of us collaborated with her and the Yale colleagues on this, Dr. Santine. So I'm really struggling with my advanced stage serous, and I have to admit I'm checking HER2 carcinosarcoma now if they have a serous component. What am I going to do with those patients? Obviously, to your point, it depends what the data looks like, right? But, I mean, again, I'm thinking the proficient population is not going to blow me away, but I'm curious to see. So are you going to just switch them all to IO? Are you going to wait? What are you going to do?
Well, I think, you know, our clinical practice has evolved based on 60 patients in a, you know, randomized phase 2 trial. You know, that's compendium listed. So it's not FDA approved. And I think depending on the magnitude of benefit, you know, if IO gets approved in that cohort of patients and the magnitude of benefit is great enough, I will use IO.
Yeah. And I think really as we look at this, and it's really, all of us are passionate about clinical trials. I hope you all are passionate. The reason we're making these huge strides is because of clinical trials. And setting your practices up, making sure the best option for a patient, and you heard this morning for platinum-resistant ovarian cancer by Dr. Morton, which is they do better if they go on a clinical trial versus standard of care of never going on a clinical trial. In this case, the reason we're making these huge jumps where we may be curing patients with current cancers participating in a clinical trial. Bob, we're down the last 3 minutes. Bottom right, increasing diversity. I know it's your passion. Can you give me a very short, and then once you do that, I want a final thought, and then Anna, a final thought, and then I'll wrap us up in the last 3 minutes.
Yeah, sure. I think I alluded to it in my talk that, we're seeing mortality, right? Rising mortality in endometrial cancer, and much of that is related to the non-Hispanic Black population. And so it is critical that those patients be enrolled on clinical trials because they are the patients that are most in need of new therapies. In that light, I loved the opening plenary this morning that really highlighted, this need to think about, modernizing our clinical trials. Dr. Agajanian gave a beautiful presentation on that, on, how we can have much less restrictive eligibility criteria. And then, the work that you presented with your fellow, Dave, also really, great in terms of increasing that clinical trial participation and the need in the patients that need it the most. My final thoughts are that that obviously the endometrial cancer treatment paradigm on Monday will change. And it's a really exciting time to be able to bring these new therapies into the front line. And it just goes to show you that the second line is wide open, and we need clinical trials, and we need everyone's engagement and participation, and really to put patients on these new trials that we're going to be developing in this space to answer these questions that we have.
Just one sentence, very short. I think we are this is a new era for endometrial cancer patients. We are changing, thanks to the clinical research, the natural history of our endometrial cancer patients.
We are curing patients with these new therapies with advanced metastatic and recurrent disease. If you are not comfortable with immune therapy, call me. I will then refer you to the nurse practitioner I work with, because she really does the work on this, right? Having a fantastic team in place. I say I should never say I. Woo, yes. So having the team around you to support, because they are challenging. Lots of people are afraid of the combination of Latinib Pembro because of toxicity. You should be afraid of not having your patients live as long as they should. And yes, do I dose at 18 milligrams because it's easier dose reduced, and I know that more than half the patients are going to be dose reduced? Is it wrong to start at 14? No, I start at 18 because they have 10s and the 4s. It's very easy to drop down, okay? That was a question that came in the audience. That wasn't my conclusion. Okay, so if they didn't get IO therapy in the first line setting, recurrent, some sort of IO regimen. If they got IO in the first line setting, we need more data.
Absolutely.
To reintroduce. Would I ever do single agent IO after somebody had progressed on IO? No. But IO exposed, to your point, 100%. Combination therapy, unique cutting edge treatments, antibody-drug conjugates, that's where we're going. Thank you for your attention. Hope you appreciated it.
Congrats.
Good job, good job.
Well done.